The House Subcommittee on Public Health and Food Security will come to order. Would the clerk please take the attendance?
Chair Beerline.
Here.
Representatives Paquette. Here. Green.
Present.
McDonald.
Present.
Cerniglu.
Here.
Mr. Chair, you have a quorum.
Representative Green moves to approve the minutes of the March 3rd meeting. Hearing no objection, they are approved. Good afternoon, everyone. Today we're going to continue the conversation regarding the closure of in-person pharmacies across Michigan. Last week we began hearing testimony about the growing challenges facing community pharmacies and the real consequences these closures have for patients in our state. The testimony made clear that this issue extends well beyond individual businesses. It affects access to care, particularly for seniors, individuals managing chronic conditions, and residents in communities where the local pharmacy may be the only nearby healthcare touchpoint. Since that hearing, the concerns we discussed have continued to resonate. Members of this committee have shared additional feedback from constituents, and pharmacists from across Michigan have reached out to describe the pressures they are facing and the uncertainty about the future of their operations. Today's hearing allows us to continue building on that discussion. Our goal remains the same: to better understand the factors contributing to pharmacy closures, the role various parts of the pharmaceutical supply and reimbursement system play, and to review what steps the legislature has already taken to ensure Michigan residents have access. With that, we will begin our testimony with Eric Roth from the Michigan Pharmacist Association. If you'll just push the red button when you're ready, and the microphone is yours, sir.
All right. Thank you, Chair Beerline and members of the committee, for allowing me to speak today. My name is Eric Roth, and I am the Director of Government Affairs for the Michigan Pharmacists Association. As we began to establish last week, pharmacy benefit managers, or PBMs, and their business practices are having a direct impact on the ability for pharmacies to stay in business and provide care for their patients. The Michigan State Legislature has actually already acknowledged this, in part, and has passed legislation that was meant to curb this problem. My aim today is to provide an overview of some aspects of that law and articulate why it has done relatively little to protect pharmacies and their patients. The Pharmacy Benefit Manager Licensure and Regulation Act of 2022 laid the groundwork for addressing disruptive and abusive practices that are harmful for both patients and pharmacies. Some of these policies include eliminating clawbacks, which are monies recouped from the pharmacy after services are rendered, or additional fees assessed after the claims are adjudicated or rather processed through the pharmacy management system. Establishing audit standards, including a prohibition on the use of extrapolation, which increases the fines associated with any findings in that audit as a percentage of the prescriptions filled under the auditing carrier, and prohibiting PBMs from establishing preferable contract terms for affiliated pharmacies, prohibiting PBMs from charging a patient more than the amount retained by the pharmacy, and lastly, prohibiting retaliation against a pharmacy or a pharmacy exercising any right or remedy under this act. In effect, that is utilizing the PBM complaint process set forth in the act. Interpretation and enforcement of this act through the Department of Insurance and Financial Services, or DIFS, however, leaves much to be desired. Pharmacy owners have shared cases brought to DIFS that have brought some disturbing instances to light. Here are a few examples. The department interprets the prohibition on clawbacks to only apply to individual claims, not recoupments made in the aggregate. This means that if an adjustment by a PBM is made on a broad scale through something such as a true-up process, which my independent colleagues will describe in more detail if you would like, this somehow makes it legal. The auditing provisions provided an exception to standard practices and prohibitions for investigations targeting fraud, waste, and abuse. This has become a pathway for any audit, particularly wholesale invoice audits, to be broadly labeled as exempt from these requirements, despite zero intention on the part of the PBMs to make formal allegations of fraud, waste, or abuse against the pharmacy. The law allows PBMs to craft structured or tiered networks, which essentially allows for PBM-affiliated pharmacies to have access to patients through plan options that are not given as an option to most other pharmacies in the area. PBMs redivert claims to contracted partners operating medication discount cards rather than rejecting these claims. These so-called discount programs assess the patient an administrative fee that goes above and beyond what the pharmacy is reimbursed. Further, these practices have significant impacts on the coordination of benefits between commercial plans and government plans, which impacts Michiganders who utilize Medicaid for secondary prescription coverage. As far as retaliation, pharmacies are only protected from PBM retaliation against formal complaints under the law. We still see instances today where PBMs clearly retaliate against pharmacies that speak to media outlets about their business practices, leaving the pharmacy without recourse outside of bringing the issue into a court of law. This has led most pharmacy owners to become afraid to fight against these harmful business practices. Additionally, many PBM contracts are not subject to the law due to the Employee Retirement Income Security Act, or ERISA, preemption that was included in the Michigan law. At this point, I want to dive into a bit of background regarding ERISA preemptions. ERISA was enacted in 1974 to set minimum standards for most voluntarily established retirement and health plans in private industry to provide protection for individuals. This includes providing participants with plan information such as plan features, vesting standards, and coverage grievance processes. It also establishes a fiduciary responsibility between the plan and its participant, something I would like to note that PBMs are not required to have based on federal law or under the vast majority of state laws. This is relevant to the PBM Act, Michigan PBM Act, due to a clause located in MCL 550.845 that states, "This act does not apply with respect to a claim that is entirely preempted by federal law, including Medicare Part D or the Employee Retirement Income Security Act of 1974. This implies that PBMs cannot be regulated due to ERISA, but the United States Supreme Court disagrees. Arkansas's Act 900 was enacted to stop PBMs from reimbursing pharmacies below acquisition costs. The Pharmaceutical Care Management Association, or PCMA, subsequently sued the state, arguing the law was preempted by ERISA. In an 8-0 decision, the Supreme Court ruled that ERISA does not preempt state PBM laws that impact cost regulation as long as they do not dictate plan design. This means that several components of the existing law, such as maximum allowable cost or MAC lists, payment appeals processes, and transparency requirements, can apply to ERISA plans as long as the law does not mandate benefits designs or conflict with other core ERISA functions. Therefore, while there is nothing to be done about the state being unable to regulate Medicare Part D plans, ERISA plans are only exempt because of that line in our PBM Act. I would like to note that that pharmacies have, knowing or unknowingly, filed complaints on claims from ERISA plans, and this seems to be the fastest way to get DIFs to dismiss the complaint. Complaints against other claims governed by the law, however, go through a far longer process. Recognizing that the pharmacy owners that will be testifying before you today can share their own experiences with the DIF's complaint process, I'm going to walk you through just one example of how the integrity of this law was tested before concluding my remarks. For the sake of privacy, I've removed the names of the entities that were involved in this specific complaint. On March 13th, 2024, the pharmacy received a notice from their Pharmacy Services Administration Organization, or PSAO, that the PSAO was recouping $11,000 for overpayments made to the pharmacy by the PBM. A complaint was submitted to DIFs on April 4th, asserting that this was a violation of MCL 550.825, Section 3, which states a pharmacy benefit manager shall not directly or indirectly, including indirectly through a pharmacy services administrative Administration organization charge or hold a pharmacist or pharmacy responsible for a fee related to a claim or reduce the amount of the claim at the time of the claim's adjudication or after the claim is adjudicated. An acknowledgement of receipt from DIFS was received by the pharmacy on April 18th. This response stated that the defendant had 21 days to respond, and DIFS had 4 weeks to review the response. This adds up to an estimated response date of June 6, 2024. On June 28th, the pharmacy reached out to DIFS asking if a verdict had been determined. By this time, the pharmacy had been notified that it had accrued up to $33,000 in so-called overpayments. A second follow-up was conducted by the pharmacy on August 19th. On August 26th, the pharmacy received the following response. Based on the information provided, DIFS is unable to conclude violations of the Act has occurred. The PBM maintains that the recoupment of funds in question was not initiated on their behalf, and further states that its claims reconciliation with the PSAO resulted in additional payments to the PSAO rather than a recoupment. The response goes on to state that there is no evidence that the recoupment was made by the PSAO at the request of the PBM. On September 13th, the pharmacy attempted reconciliation directly with the PSAO. Following inability to reach a satisfactory conclusion, a complaint was filed with DIFS on October 30th, 2024 against the PSAO. On February 17th, 2025, the pharmacy reached out to DIFS for an update on the progress of the complaint. On April 30th, the pharmacy received a response from DIFS stating, the definition of PBM as specified by the Act does not include pharmacy services administrative organizations. Please understand that DIFS authority extends only to those entities that are licensed by our office. As such, our office contacted the insurance company to address your concern. The insurance company has advised that the claims in question are related to individuals enrolled in Medicare Part D prescription drug case. Note that in this case, there were many claims that were not, in fact, related to Medicare Part D. However, if this is true, this should have been discovered at the very start of the process. I will note, based on other complaints I've received, DIFS has gotten much better at identifying exempt claims. The statement goes on to advise you may consult with an attorney to discuss your concerns regarding actions taken by the PSAO. That same day, the PSAO unilaterally terminated its contract with the pharmacy. No retaliation complaint was filed with DIFS, as the pharmacy had already been notified that DIFS did not have any enforcement authority over PSAOs. Aside from taking note of the egregious time frame over which this saga played out, I would like members of this committee to note the relatively vast amount of input the PBM had in the department's interpretation of the law, if not law, and the glaring loophole that, in this case, allowed the PBM to violate the spirit of the law, if not the letter of it. Subsequent cases that did not involve the specific situations of the PSAO in question here have resulted in the department's interpretation that payment recoupments in the aggregate, again, are not prohibited under this act. In conclusion, I would like to urge members of the Michigan legislature to take swift action to protect pharmacies and their patients. The PBM Licensure and Regulation Act must be revisited to close loopholes and reduce applicability of the reforms intended with the law's passage. I've included some policy recommendations on this slide. More oversight power must be given to DIFS to allow for thorough audits of PBMs, faster complaint processing, and substantive penalties for PBMs that fail to comply with the law. Alternatively, the ability to have an agency such as the Department of Licensing and Regulatory Affairs or the Attorney General's Office assume oversight responsibilities for PBMs may work to obtain timelier, more satisfactory resolutions to complaints. Thank you again for the opportunity to speak with you today, and I would be happy to answer any questions you may have at this time.
Thank you, Eric, for being here. Independent pharmacy closures in Michigan, are they at a different rate than what we see nationally, or is this a Michigan-specific issue?
Michigan has a somewhat unique situation. So overall, the trend is similar over the past few years, as I understand it. However, last year with the pullout of Rite Aid in Michigan, there was actually a slight uptick in independent pharmacies because there was a hole to fill in these neighborhoods where sometimes your Rite Aid was your only pharmacy. So some pharmacies opened to try to address these patients. Now, those pharmacies are seeing the problems with the patient mix and the coverage in those communities. So it's questionable to see how long that will be sustainable. But overall, you are seeing a decline over the past 5 to 10 years that is actually accelerating in the independent pharmacy growth here in Michigan.
Is that rate, I guess, is in-person pharmacy, whether it's chain or independent, is it at a similar rate? Are independents closing at a faster rate? I understand, Rite Aid and Walgreens were big players, and we lost a lot of pharmacies in the state. But I'm just curious if you're aware how those correlate.
Chair, I do not have those numbers for you, but I'd be happy to follow up with your office.
Okay. Can you help walk us through how PBMs would set a reimbursement rate for prescriptions, and how those reimbursements can fall below the cost paid for a medication? So, I think it'd just be helpful for all of us to kind of hear that explained.
Yes. Certainly. So reimbursement rates for pharmacies are established via contract terms. They generally reference a independent set of pricing standards through companies like First Data Bank is a common one that assess the average wholesale price, for example, of a medication. They also have various metrics like wholesale acquisition costs, et cetera. Then the PBM has a number of ways in which they formulate, based on individual contracts, what the pharmacy is actually paid. It will usually be AWP minus a certain percent, or for commonly used generics that have a lot of competitors in the market, they'll set up what are called maximum allowable cost lists, which basically just says, here, this is what you should be reimbursed because this is where the purchase price is relative to other competitors in the market. This, in theory, has the practical effect of encouraging pharmacies to buy the cheapest available product. However, many times a pharmacy cannot actually find and purchase from their wholesaler a product at a price that is above the reimbursement level. Additionally, when you look at these contract terms, and again, I know that Medicare is not necessarily part of this discussion, but Medicare has been notorious where they are increasingly ratcheting down the reimbursement to average wholesale price minus 30%, 40%, and it's continuing. That percentage subtraction continues to grow each year. And just quite frankly, pharmacists cannot find the medication at that price to sell to their patients.
In the diffs complaint that you mentioned, the recruitments grew over the course of the complaint from 11,000 to 33,000. So whatever the original complaint was that allowed for the clawback or the recoupment, if we want to call it that, whatever that complaint was continued to happen so that by the end of it, it got to 33,000. Am I understanding that correctly?
Yes, sir. So the way that recoupment process works is through what's called a true-up process. And this, again, is a contractual mechanism that states that a group of pharmacies under a similar contract will be reimbursed for a generic drug or a brand name drug at a certain rate. For some reason that I cannot begin to fathom, the PBMs will reimburse pharmacies under this same contract different rates, and it results in overpayments and underpayments. Now, I have a colleague that works for a transparent PBM that I would love to get you in touch with, and I asked him, how does this occur? What's the error in the process? And he said, honestly, I don't know how it occurs. I would have to do this on purpose. All right. This leads to a reconciliation process that occurs retrospectively, months, sometimes years after the claims have been processed, in order to true up or make sure that you actually got that rate. So it's a reconciliation process that's managed by the PSAO. However, the PSAO has to do this because the PBM forces that into their contract. That is why the clause say directly or indirectly requiring a recoupment through a PSAO is there, because these recoupments are indirect based on the unfair contract terms that the PSAOs are forced to accept.
How common is it for a pharmacy to go through this process? Is it a couple times a year, once a year? Is it once a month, couple times a month?
At least annually.
At least once a year?
Yeah, some of my colleagues testifying after me would be able to talk about their experience, but it's at least annually.
Okay. I'll pause for a minute and go to Representative Green.
Thank you, Mr. Chair. This is a little bit overwhelming. So you said that Michigan passed transparency laws with the PBMs, and they came into effect, what year? Recently, 2024, is that what you said?
January of 2024,
So,
yes.
because I know I'm learning as a legislator that sometimes laws need a little bit time to marinate and we jump on things too fast. Do you think that they still need time to marinate, or do you think that we need to change things more, just in your opinion?
In my opinion, I think that there was a lead-in period to the effective date of the law for a good reason. I mean, the law was passed in 2022. There was a 2-year lead-in period. I don't think the appropriate steps were taken to prepare on behalf of the department. I do think the department is getting better at enforcement, but I think that they're just frankly ill-equipped. I mean, I would be very interested to hear their perspective on what the challenges are. But I do not see, with the way that they have allowed their interpretation to be dictated by their licensees, which are their PBMs, I don't see how it's going to improve on some of these violations and rectify the core issue, which is that these practices are making independent pharmacies close. I think action immediately is necessary.
Thank you.
I want to go back to this situation that you put up here, and I want to talk a little bit about the PSAOs. So is leading up to this, and I don't know enough about them to understand how this process works. So could you explain to me a little bit about how that relationship works between the pharmacies themselves and the PSAO? Like, how do you pick one? How do you become a member? What does that relationship look like? And then how is that PSAO relationship with the PBM, if you're aware of how that works? So whatever you can share on that would be helpful.
Certainly, and one of my colleagues would be able to elaborate in more detail, but the simplest explanation, as I understand it, is that a pharmacy takes part in a PSAO which handles contracting directly with the PBM.
So is every pharmacy a member of a PSAO? Like, if I was an independent pharmacist, would I have the right to not join a PSAO and try to negotiate on my own, or are they going to tell me no, like I'm not going to negotiate with you because you're too small and I want to do it on a group setting?
Yes, sir. You could theoretically try to make it on your own. Most buying groups have the PSAO just so that you're reducing the administrative burden of maintaining and auditing these contracts and their various changes. But theoretically, yes, you could. Is it very practical? Not so much. I know some pharmacies prefer to go through all direct contracting, but it's very normal for pharmacies to be part of buying groups associated with PSAOs in order to increase their purchasing power. Because again, even with these groups, pharmacies are having trouble finding the medications under the cost being reimbursed. If you were to go at it purely solo, good luck.
So when you say buying groups, can you, I guess I would have thought that's what the way that I read it, or the way it is described, like I would have thought that's what the PSAO is a buying group, basically, where they're negotiating for me, because I believe they're owned by most of the wholesalers, if that's correct.
As I understand it, your PSAO is kind of the administrative arm that's often associated with the buying group, but they're not necessarily the same thing. The buying group, in the purest sense, is the pooling of resources to negotiate prices for drug acquisition.
And then you did mention, so under the act in 22, sorry, I got distracted. Under the act in 22, so the PSAOs are not regulated, but the PBMs are. And so you're suggesting that PBMs use the PSAO to claw back because they can't? Is that through their contract? That's what you're saying, right? I just want to make sure I'm understanding everything and I've got the right information.
Yes, that's what we're seeing in the instances that are being reported by my members.
Okay. Can we go back to ERISA? That is, I think, a complex addition to all of this. That if you could give us that clause or that in a, talk to us like we're fifth graders kind of thing, that'd be.
Second graders.
Sure. So think of health plans as falling into various categories. So you have your state Medicaid plans, you have commercial plans, you have Medicare plans, and ERISA governs employee-sponsored plans, I think is a good way to frame it. And certain protections because of those plans' structures were established federally in the 70s. What happened when Arkansas tried to address the fact that their pharmacies were being under-reimbursed is they put in a mandate that pharmacies could not be reimbursed below actual acquisition cost of their drugs. Immediately, PCMA came in and they said, well, no, because you have this act in the 70s that says you can't mess with these plans, which, mind you, PBMs weren't even close to their current business model if they even existed in the 70s. It worked its way up through the Court of Appeals, and through a unanimous decision from the Supreme Court, they said, well, no, as long as you're not affecting the plan design, which is what ERISA was originally intended to do, then yeah, you can regulate PBMs. They don't have the same fiduciary responsibility. Really, they're a contractor with the health plan. They work very closely with the employer-sponsored plans, but they are not that plan. So as long as you're not forcing a certain structure onto the health plan, then the state has the power to regulate plans that would otherwise be protected under ERISA.
Okay, you mentioned the can't be reimbursed at less than acquisition cost. Drawn a blank from the term for that from last year. I know there's a national kind of average on what it is.
NADAC, the National Average Drug Acquisition Cost, NADAC.
Is that the one that we talked about last week? Okay. I've read some complaints on that number that there's not enough people who participate in the input of data to get an accurate price. Is that something? Is that something the state should consider? Like, if we want to get a good price on what it costs to actually get that, is there another level of reporting that needs to happen at the pharmacy level, so that we know what that data is and that it's accurate?
Mm-hmm. Absolutely, and MPA actively encourages its members to participate in these surveys so that their buying power and information is adequately represented in that number. As far as mandated surveys, I'm not sure what other states have done, so I can't comment on the effect that it would have. But we definitely encourage more pharmacies to participate in the survey.
And then I think kind of the last one that I have you mentioned like rebates and how that process works, and I think that is another one. If you could give it to us in the second grade vernacular, that would be helpful for everyone.
So at the risk of sounding cynical, I think the summary from the testimony last week is that you could say that the definition of a rebate is an overcharge. Basically, these are, quote, price concessions that are obtained from the manufacturers. So it arguably makes the manufacturer start to price this in, which you could really draw a direct line into the rapidly increasing drug price problem with the so-called rebates that are being negotiated by these PBMs. Now, there actually is a state transparency report where PBMs in the aggregate have reported how much they have passed back on to their plans and the beneficiaries and how much they've retained. I would encourage you to look at that number. I don't have it off the top of my head, but I remember it was actually quite impressive. So these are things that the PBMs negotiate in, which make drugs more expensive for your average citizen and directly adds to their bottom line.
I think Representative Green has a follow-up question.
Just to entertain me on math of that. Okay, so a drug manufacturer needs to, of course, recoup their cost of their research, running their business, all that took. So let's say it cost $500 per pill. I'm just using basic, okay. So from what you're telling me, from how I understood that, is then they actually then charge $1,000, but then give you a coupon to pay $750 for it or something, but then it changes depending on the requirements that were met to get the coupon? Is that?
So let me use a non-drug example. All right. Let's say I farm apples. I grow apples, and I want to get them into a supermarket. But rather than going to a supermarket, I have to work through an intermediary. And the intermediary says, well, I know you want $5 an apple. I know that's ridiculous, but let's run with it. Yeah. $5 an apple, but I want to offer this to the store at $3 an apple. So I need you to reimburse me $2 back, or I'm only going to give you $3, so you're not going to get $2, right? And the intermediary would keep that $2 and then sell it at the supermarket for $3, right? Well, I am still looking to profit. So I will go, okay, well, I'm going to be losing that $2 to get it over into the market. Why don't I just increase my apple price to $7? And then the intermediary still keeps its $2, and then it goes back to the grocery store shelf at the $5 that I intended it to. That is similar to the theory with how rebates are working to actually increase pharmaceutical costs. So I have my medication that I want to go to market at $1,000. Well, a PBM negotiates a payback off of that $1,000 to say, like, okay, I want $200 back. Well, in order to keep my profit margins over here, I go, fine, I'll give you your $200, but then I'm increasing my price to $1,200. Is that better?
Yes. It's still, so then using the Apple example, do you always have to have the intermediary? I can't sell directly to people?
So there are direct-to-consumer programs. I'm not prepared to talk about those in depth today. You're seeing increased popularity with that, with some of the like Mark Cuban kind of models, or Trump RX has brought to light a lot of interest in direct-to-consumer programs. But those right now are not the standards in the marketplace.
Okay, thank you.
You mentioned that under the current regulation, the enforcement mechanism on diffs for reporting, I think your words were, left much to be desired. Can you talk about what gaps you think are there?
Certainly. One, I think just the time frame and the ability for the department to respond in a timely manner is rough. I mean, when you look at the initial response, and granted, this case was one of the first tests of the law we did right in March of the year it went into effect, and they estimated it was going to take, about 6 weeks to resolve. And the reality is that this investigation, for whatever reason, and I do not know what that reason, it very typically goes on months or years, rather than having a resolution in a tight time frame. I would also be curious to know, out of the complaints that the department has received, how many are actually ruled in favor of the pharmacy? Because what we saw in the response was a lot of communication between the department and the PBM that, in our opinion, shaped the department's interpretation of the law that doesn't happen when you're communicating with the plaintiff, the person filing the complaint. So again, I'm not sure what to do about how the department is interpreting the law, but I would be very curious to know what their process is, why it takes so long, and how they come to their conclusions on any given complaint.
And then the last one that I have for you, and we'll let you go. I just kind of, experience, opinion, the feedback you're getting from your members. If you were to look ahead 5 to 10 years, what do you think the state of our in-person pharmaceutical access is going to be in Michigan under the current model?
If nothing changes, I think you're going to see a lot more patients rely on mail order. I think you will see a consolidation in the marketplace because the amount of debt some of these stores are having to go into just to stay operational, and the various strategies, which again, my colleagues can talk about their own stores and strategies that they have to circumnavigate just to make sure patients can get their life-saving and maintaining medications is mind-boggling. Something needs to change. Otherwise, the pharmacy market in 5 to 10 years is going to look drastically different than it is today. And I'm not sure if independence will be a part of it.
Thank you. Actually, Rep. McDonald has a question.
Thank you, Chair. Just kind of a big picture question. How are cuts in Medicaid and the ACA subsidies expected to exacerbate these problems with independent
That's an
pharmacies?
excellent question. So when you look to future policies and how we can work with the team over in the Medicaid pharmacy division, which I would like to note are excellent partners for us, we have trouble with getting things like a cost of dispensing study to accurately reflect how much it costs for a pharmacy to dispense a medication, because the department's budget as a whole is shrinking. So these cuts aren't necessarily a good thing for pharmacy or our patients, because it gives us very little wiggle room to try to change the system with partners who are very much interested in working with us.
Okay, seeing no further questions from the committee. Thank you, Eric.
Thank you.
Appreciate your time. Next up, we have Steve Jensen. Steve is representing Jensen's Community Pharmacy in Saline and Dexter. Steve, just push the red button where you're ready. Thank you for being here.
Yeah, thank you for having me. Appreciate the opportunity to speak on behalf of myself and especially my local colleagues around the Ann Arbor area, and to discuss the challenges of delivering healthcare in this current climate, the current business climate, and the noticeable difference since when I started my first pharmacy in 2012. Pharmacists, make the engine of healthcare, hum. So we're on the front lines every day. We're often the first point of contact for patients in the healthcare system. We're visible, we're available, and we triage patients every day. The classic, hey, can you look at this? Sort of an interaction. And so we're able to either make sure they get referred if they need to, or if they're able to, use self-care, and we can give that expert advice. In the meantime, we're probably saving the healthcare system, boatloads of money just by making sure the patient's not overutilizing emergency services. We help patients navigate the healthcare system, especially my area in Ann Arbor. We have 2 large healthcare systems that have all of the specialists. So some patients have 5, 6 doctors at a time, and we actually have to help coordinate some of that sometimes. We educate and empower patients to be their own advocates in this very, very complicated healthcare system that we have. We sync medications so they can pick them up all at the same time, so they're not coming 2, 3 times a day, a week. We package their meds for compliance purposes with the date and time of administration to increase the compliance and the outcomes. We deliver meds. We compound meds. If you're not familiar with that, that actually is, creating, the medication from scratch when the commercial version, or it might not even be available. We have to do that for many patients, especially very sick children. and we also do it for pets. We give thousands of vaccines. We have a particular eye that we can look at patient cases differently. For instance, I had a patient who eventually complained of a chronic cough that they've had for a year. They got worked up by the physician, probably multiple, because they're going to look for everything, right? They go, okay, is it COPD? Is it asthma? Is it cancer? They go through everything. Eventually, he's sent on his way, can't really find anything. Here's an inhaler. It takes me about 10 seconds to look at his profile and realize he's on medication that causes a cough. So 3 weeks later, after we recommend to change the blood pressure medication, voila, it's almost gone. Help patients choose Medicare plans. That's a whole other job, right? And do we support the community projects, support the school sports, support our local businesses? Sometimes we're just there to chat with patients that may not have that many relationships left in their life. All this takes time and money, though, doesn't it? More and more of our time is spent managing the PBM's labyrinthine formularies for which we end up being unpaid insurance agents for them. Between step therapy, prior authorizations, quantity limits, brand versus generic preferences, the esoteric, garbled rejections that we get over the computer that actually we call and even the PBM's own help desks can't decipher. So that's all the stuff. We spend a lot of time communicating with doctors' offices then. And then that puts another burden on the office as well, because they have to end up having to resolve a lot of these issues. In the meantime, we're communicating a lot with the patients to even help them understand as far as we can and help them navigate this whole process. And we can understand, I think, the usefulness at times of trying not to use the most expensive medication when something else might work that's cheaper. However, we are seeing these administrative burdens even on cheap medications. We're talking under $10. And we're still having to go through this whole process for a patient. We see PBMs only cover specific manufacturers of a generic, which in turn makes us spend a lot more time shopping at all of our various wholesalers to see if we can even find the one that they're preferring. We see a lot of arbitrary limits on the quantities. So a patient needs 2 a day of a particular strength. Insurance only wants to pay 1 a day. We again see this even on penny drugs, and I call them penny drugs because we claim that for a 90-day antidepressant claim that just came through, total paid was 48 cents. But mind you, this was down from 56 cents the month prior. So I guess everyone has to tighten their belts, right? It's more common now too to see the brand name drugs being required to be dispensed over the cheaper generic. And that's most likely because the PBMs are getting large rebates on the back end, which makes it cheaper for them overall. But when it comes to a patient that has a high deductible, that may not work. I have a patient with a particular eye drop that has a fairly cheap generic, but his insurance, in order to cover it, is requiring the use of the brand name. However, due to the high deductible, his cost share is almost $500. So with discussion with him, we've just bypassed the insurance altogether, and we can cash it out for him for about $100 a month. And overall, luckily he can afford that, but what is the insurance good for? All the time when we're managing all this, we have to watch our claims like hawks, right? This is something that any clerical error, anything that could be construed where the PBM can come back, 2 years from now and want all their money back for a claim. Speaking with a colleague yesterday, he's undergoing one for Ozempic, which is a popular GLP-1 for diabetes, which we lose $25, $75 on just to dispense in the first place. But they're coming back a year and a half later to try to take back all 3 fills that he did for a patient for $2,700 because the doctor had a diagnosis code on there that they didn't like. However, that diagnosis code was attached to the claim to begin with, so they approved the claim. But come back a year and a half later with sour grapes and want all their money back. And he's probably gonna lose his case. I would imagine he's just gonna have to give back all that money. Another dip into our time. You just heard about maximum allowable cost, or MAC, is the way that we are paid by the majority of generics, and there is a so-called MAC appeal process that we can use to notify the PBMs that hey, this is way under cost here. That mechanism takes 5 to 10 minutes probably per claim. Mind you, even if it's a same insurance and same drug, same everything, you have to, every claim has to be individually done for each patient. I haven't really seen much luck with these. There's one PBM that actually has been responsive. The other two, never really seen much. And I have another colleague that has been doing his due diligence to see if this process actually works. And he has a stack of 81 appeals, exactly 81 rejections. So the PBMs, they create these MACs, arbitrarily, but also they know exactly how much we're paying for these things. This is no longer a mystery. They know the supply chain and what, especially our class of trade, is paying for these things. They just don't care. And I think most importantly is they know that they don't have to care. Lastly, I just wanted to touch on mail order. Mandatory mail order. So this has gotten a lot more common where patients are required to use a particular mail order house, which is usually the PBM owned mail order house. I believe this should be a patient choice. We see some very complex patients with very complex medical histories that would always benefit from more face-to-face healthcare contact than fewer instances of that. I had one patient in the past that we were doing those blister packs for, that got a letter eventually that said, hey, you need to go to our mail order house in order to continue getting your medications paid for. And luckily they were on some fairly low-cost generics that were able to just cash out, and they were able to afford it in order for them to continue getting the services that they needed. We're also called upon to save the day when mail order companies fail at their jobs, which is frequent. How many patients haven't gotten their medications in time? Oh, they filled the wrong strength. Everything else you can think of, but it takes 2 weeks for them to, from start to finish, to get the medication to the patient. So we're called upon to, save their bacon. We have to get a new prescription from a physician. We have to call the insurance company. These are not short phone calls, by the way, to get an override for a 2-week supply in order for the patient to have the medication that the mail order house was supposed to get them on time. If we weren't around, mail order's going to be having a lot more complaints, I think. And also, typically patients that are required to do mail order, they still have to get their controlled substances filled through us locally. And that puts us in a bind because, we have a lot of patient profiles that just only have controlled substances, which the DEA loves to see, right? But also the way that we purchase from our wholesalers by volume, the controlled substances, we're limited by how much other stuff we buy. So it can't be an over percentage. And so that can put us at a risk of not being able to really meet the demands of our local population. And also just as a Michigander, you kind of hate to see that amount of dollars flow right out of the state. So I guess overall, unfair reimbursement, administrative burdens, it's definitely making delivery of healthcare just much more difficult each year. I would love to see something happen before the profession implodes. As a local owner, another local owner I was talking to, he just cashed out his IRA to infuse his business to keep it rolling. That was partially due to the new Medicare payment stuff, which we're not really talking about today, but he could never really build up the cash stores to prevent these sorts of things. So Overall, you're noticing it's not just an independent thing, right? Just ask, Rite Aid and Walgreens. Even CVS, probably couldn't manage their stores unless they had their vertical integration. Monopoly is a better word for it. So, so I really thanks for allowing me to speak, and I can answer any questions, or try to anyway, if you have any.
Thank you, Steve. I do have some questions to follow up. So I want to start with, I think Eric called it the true up, or we can call it clawback, whatever term resonates so that people know what we're talking about. How big of a window is that time frame for when that process can be initiated after payment's been received by a pharmacy?
Yeah, generally, when I was with a PSAO, when Optum took over for Blue Cross Blue Shield, they immediately started a GRBR contract, which are these retroactive clawbacks. So they true up every year. I went independent eventually and immediately was taken out of those. They like PSAOs because they can aggregate claims data and extract more money from 3,500 pharmacies versus if I'm a single, independent pharmacy contracted with them. They're really not able to do these arithmetics that they love doing. It sounds like those are still going on, but yeah, it sounds like about a yearly, and it's usually in the tune of, depends on your volume, at least 10 grand though every year. That just kind of, that was profits that you were thinking that you had, but you don't.
To your knowledge, there's not a set window that, they have to start the process within 6 months of a claim, or they have to start within a year. I'm just curious. I just didn't know if that was something in the 22 rules that said you have to start this process within a certain amount of time from when the claim was paid out.
Yeah, not that I'm aware of. Just all my communications when I was with Elevate, the PSAO with Amerisource, they seem to just do it on an annual basis, and they would talk to you about, okay, we're in talks with, this PBM or this PBM, and we're trying to reconcile to, get this as low as possible because you're going to owe them some money, but you don't really know what that is until you get the bill, and then they'll just pull that from your bank account, or they'll just garnish your claims going forward until that's paid off. So.
Okay. The other thing I wanted to ask about was the discussion around mail-ins or mail order scripts. So, other areas of medicine that I'm more familiar with than this, a doctor can say, "Here, you need physical therapy. Here's a place to go." But as a patient, I have the right to choose any place I go. So you're saying that who is directing the patient that they have to get the script from a mail order source?
So the PBM will generally sell a plan to a, because there are go-betweens, between Blue Cross Blue Shield and, Aetna and all these kind of things. So they'll sell a plan to an employer that may include mandatory mail order, or like a local hospital system in where I'm at, they can fill up to 3 times before they're required to go to mail order, or pay out of pocket. And a lot of people just don't even want to do the hassle, so they do just pay out of pocket a lot of times. But yeah, so it's the PBM designed plan that is requiring the use of that. If patients think it's super cool and it works for them, that's awesome. But there's a lot of patients that lose their ability to access services that they need by just kind of treating medications like widgets and what have you.
So it kind of, I guess, to dumb it down, like in-network, out-of-network kind of thing, where you can only go to certain hospitals that are in your network or certain doctor's offices in your network. And so they're basically saying, like, you're not in network for this type of treatment, but then if it's other types of treatment, like you mentioned, like opiates, then you are.
Right. So they'll have like the one I was speaking of, where they can fill up to 3 times. That then after that they consider that maintenance medication, which has to go through mail order. So we can still fill their antibiotics and, more of emergent type care. But anything that is eventually triggered to be a maintenance medication, must go through them. Yeah.
How does the patient keep track of that? Like, when do I have to use this person versus when do I have to use that person?
And that's part of, some of the laborious admin work that we do. We do have to help them try to figure out how we're going to get, this medication. And a lot of times when we get this rejection, oh yeah, you have to go mail order. Oh, they didn't know they had to. Okay, it's going to take 2 weeks to get there. So it's very difficult to get the PBMs to even give us any sort of override to fill it, one more time, so they have chance, to get into the mail order system and then actually get their medications mailed to them.
Okay, looks like Representative Green has a question.
Okay. This is such a very complicated issue. It's also a very personal issue because, like, some of us, myself included, are impacted by this. And so I know I have constituents impacted by this who ask these questions, and also business owners. So I live in a very rural area. We don't have the convenience. My town has a CVS, but the rest of my district doesn't. And at miles, 2-hour drive away, there's nothing, and so except for the independent pharmacies, which you said offer those services. I know they put together these packs for these little privately owned nursing homes to keep track of their medication, but they're telling me that they can't afford to do that anymore because it costs them more to do that than they get back in their reimbursements. There's so many layers to this because yes, lisinopril is a little naughty drug. I know which one you're talking about because my vocal voice has changed to that, but nobody is able to identify that, and then they won't give me an alternative. That's a whole nother conversation though. But also with allergies. So I can't have red dye, and I can only go to Express Scripts for more than I get 3 fills and then I'm done. And then the Express Scripts has actually told me we can't fill your medication because we don't offer that. And so I had to go pay cash at an independent pharmacy to get my medication, which is crazy when you think about all of these hoops that I have to jump through just to get a simple drug. So, and I could ramble on about this forever, but I guess the bottom line is how I want to save my independent pharmacies, because that's all we have in our area. Otherwise, they will have to do mail order. There's no personal consultation. There's no, even we still have people we actually have areas where we don't have internet and even crappy cell phone service in my district. So those folks can't even like Google search stuff. So their pharmacist is their place to go. Like that's one of the meeting places, one of the people they talk to. So to preserve independent pharmacies, in your opinion, what do we need to do then as a state? And I don't want this to be a us versus them, because it just seems like it's like the little guy versus the big companies and these PBMs and stuff. But I think there's got to be a happy medium in this somehow. And I would love to weed through the weeds to find that way. Do you see a pathway forward?
Yeah, well, certainly. We decided a long time ago for some reason that really we only get paid based on the cost, the medication essentially is what we're getting paid for. Every other service we do is unpaid, so unless that changed drastically, we really do have to just say, okay, well, 48 cents for 90-day supply isn't really going to do, that's nothing, right? That does not even get to cover the bottle label, the 5 minutes it took to fill that is just
the consultation.
Exactly right. So we're on the hook for a lot of administrative and professional duties. So yeah, we do have to, I think, make a fair price on a drug. And the thing is, specialty is where everybody's making money right now, but we're not allowed to do that. So
is that because you need a separate licensing to compound?
They just like to keep all the business for themselves.
Oh, you're talking specialty is those extra,
like the $23,000 drugs or something,
yes.
but
okay.
They're making tons of money on it, but they like to keep it in-house. But yeah, so we do need to look more at the, I believe anyway, more like the model that we're using in Medicaid right now, right? Which is the NADAC plus a fair dispensing fee. Which has to be updated from time to time, especially post-COVID. Our labor is a bit more expensive than it used to be. So and it's been fairly successful in other states, where we wouldn't actually be leading the charge in any way there. We would be looking at other states that have had it going for a few years now that actually have data to show that the scary proposition that the PBMs will say, if we increase the prices to the pharmacies, is that now it's just going to all fall on the patient. That doesn't seem to have been borne out in some of the states that's been enacted. So it really does seem like a reasonable formulation, and this really does stop them from doing their major spread pricing and other things like that. So pretty much they're acting more of like, this is a known cost, here's a known dispensing fee. It's easier for employees to track, how much things actually cost, and not under the multiple layers that you're trying to understand all those rebate structures and things like that. So that's ultimately I guess I could be wrong, Eric, but it seems like
so
that
you're
would be
essentially
that
saying
would seem
that
like it'd be
other
reasonable.
states have accomplished this.
Oh, yeah. There's a
they
handful.
found a happy medium between the big folks and the smaller folks, so that manifest destiny is possible.
I believe so, yeah.
Okay. Just another question, because and this might be a little bit off topic, but you brought something up important, especially concerning like lisinopril and going to all the doctors to find. How do I put this without it seem? Do you think it could be possible that pharmacists could actually prescribe medications as well? Do you know what I'm saying?
Yeah, under collaborative practices, that is a thing that can happen, even right now. But again, what is that anything that's reimbursable?
But that relationship, like if you had that relationship with a primary care physician and was able to talk about the pharmacology of what could be causing some side effects, that would be able to treat a patient better then.
Oh, definitely. I mean, the collaboration is where it should be. Of course, due to the consolidation of all of our healthcare systems too, it's harder and harder to have those direct relationships with a lot of the physicians that we used to really rely on to actually figure some of these cases out, much quicker than, a year. So.
Thank you.
Thank you, Steve. Appreciate your time.
All right, thank you.
Next up, we're going to have Jordan Marchetti, representing Drugstore of Iron Mountain, Norway Pharmacy, and Crystal Falls Pharmacy. So Jordan, if you just push the red button and get
Thank you for the opportunity to provide testimony today regarding PBM practices in independent pharmacy. My name is Jordan Marchetti. I am the owner of TDS Inc., which has the 3 pharmacies you said. Our pharmacies employ 70 dedicated individuals that provide retail pharmacy services, long-term care pharmacy services, and clinical care programs. We serve patients across 5 counties in the Upper Peninsula and 2 counties in northern Wisconsin. We're very rural. Many of the communities we serve are medically underserved, and our pharmacies often function as one of the most accessible healthcare providers in the area. We partner with assisted living facilities, halfway homes, adult foster care facilities, mental health facilities, and provide medication and strips to support adherence, outcomes, and to optimize their medication regimens. While our pharmacists and our staff are committed to improving patient outcomes and maintaining access to medications, the current practices of pharmacy benefit managers, particularly the use of effective rate contracts, in my instance, are placing our pharmacies at severe financial risk and threatening patient access to care. Under these contracts, pharmacies are reimbursed at a variable rate with the promise of a future true-up reconciliation. We bill claims, get paid at that level, the contract rate, above it or below it. And sometime later, the amounts are recalculated, and we either pay in a lump sum or we receive a lump sum. This used to happen in the summer of the next calendar year for the previous year's claims. Those reconciliations have been consistently getting postponed. We have not seen a payment since 2023. We still have an outstanding reconciliation from the claim years 2022 through 2025. In many cases, Pharmacies are paid below the actual cost of the medication. The final reimbursement is unknown when the prescription is filled and dispensed. It's controlled entirely by the PBM with very little transparency, and it makes financial planning nearly impossible. For an independent pharmacy operating on extremely thin margins, this structure creates unpredictable and unsustainable financial conditions. Since 2022, our pharmacies have been under-reimbursed by approximately $350,000, primarily due to the effective rate reimbursement practices imposed on us by OptumRx and to a lesser extent CVS Caremark. For a small independent pharmacy operator serving rural communities, a loss of this magnitude is not simply an accounting issue. It directly impacts our ability to invest in staff, provide services, and patient care. We have had to abandon clinical programs and cut corners on staffing to ensure the survival of our business. In February of 2025, I learned that our PBM reform bill here in Michigan contains specific language preventing this activity. It reads, "A pharmacy benefit manager shall not directly or indirectly through a pharmacy services administrative organization charge or hold a claim at the time of the claim's adjudication or after the claim is adjudicated." So, gathering that knowledge, I submitted a case against OptumRx and CVS Caremark to the Department of Insurance and Finance, including all evidence of claims processed and underpaid after 1/1/24. I've continued to send data. They have all my claim data from 24 and 25. The data is clear and includes the amount paid at adjudication above or below the contract rate. After a considerable amount of follow-up on the case just last month, a year later, I received a ruling from DIFS concluding there was no violation by either OptumRx or CVS Caremark. The PBM stated, while they cannot speak to the reconciliation process of the PSIO, they do not reduce individual claims at the time on or after adjudication. DIFS went on to say, given that a PSIO is not a licensed insurance entity, DIFS does not have jurisdiction in pursuing this any further and to contact an attorney if I'd like to pursue the case in any more detail. This was the ruling despite the thousands of individual claim examples I gave them explicitly showing payments outside of the contract rate at adjudication by the PBM directly. Independent pharmacies are often the only pharmacy within miles. When reimbursement becomes unpredictable or consistently below cost, it threatens the ability of these pharmacies to remain open. If we were to close, people would have to travel long distances to obtain their medication, sometimes 30 minutes to an hour, reduce access to pharmacists for medication counseling, increase medication non-adherence, and in the long term, we'll see higher healthcare costs due to unmanaged chronic conditions. Our pharmacies provide much more than just dispensing medications. We do medication management. We service the long-term care facilities I mentioned. We do clinical services, nutrition counseling, and patient counseling on a great deal of complicated cases. We also coordinate with local physicians and many different types of care facilities. These services are essential in rural healthcare ecosystems, yet PBM reimbursement structures fail to recognize or support them. There is a lack of transparency with PBM contracts and inadequate reimbursement structures. PBMs control the contract terms, control the reimbursement formulas, which are subject to their own making, control the performance metrics, and control the audit process. I don't know why a competitor in the space is allowed to audit me. Pharmacies have little ability to negotiate these terms and often must accept them simply to remain in networks and continue serving their patients. This imbalance of power allows PBMs to shift financial risk onto pharmacies while retaining control over the reimbursement outcomes. Independent pharmacies like ours are deeply embedded in the communities we serve. Our goal is simple: to ensure patients have reliable access to medications and the clinical care they deserve. However, current PBM reimbursement structure creates an environment where pharmacies are expected to operate without knowing what they will ultimately be paid, or if we do know what we're going to get paid, it's often below our cost to dispense. Our experience with the $350,000 in under reimbursement since 2022 demonstrates how unsustainable these practices have become for independent pharmacies. This isn't lost profit. This is reimbursement up to the baseline cost of the medications we've dispensed years ago. Without reform, many rural communities across the state risk losing essential pharmacy services. It's happening right now. We've seen Rite Aid exit. Walgreens is also exiting, and other independents that I know have closed. Please don't let me be next. Thank you for the opportunity to provide this testimony.
Thank you, Jordan. I'll try to be quick because I know we have a couple other people that still would like to speak today. So do you sell non-prescription medicines at your facility?
Yeah.
Like walk in and get some Claritin or something?
Yeah, we actually have a very large front end. We sell a lot of different things.
Okay, so if I was going to come into your store and buy vitamins, like it's clearly marked and the price is there, and you know how much you paid for it, you know how much you're going to sell them for to get your profit margin. Does that price change if I have a Rolex on?
No.
Okay. How do you determine those prices?
Usually we just calculate a fair margin. Sometimes the companies we buy from dictate what margin we're allowed to make on the products. It's usually somewhere between 35 and 50%.
Okay. Would it make sense to have a set price for behind the counter pharmaceuticals?
Absolutely.
Would you support having a set price plus a dispensing fee if that set price was the NADAC rate?
NADAC is probably the best marker that we have right now. I think that's fair, and what I've seen in the marketplace, it seems to be fair based on what I know we're buying drugs at. So yes, NADAC plus a dispensing fee plus a small percentage so that we could have some profit would be great.
And then I guess my last question with that would just be, so when it comes to NADAC, as I previously expressed, there's some concern that not enough people report. Would you guys support mandatory reporting on that, or at least an annual audit that gives a spread of different drugs and what they were purchased for?
So there's much different sourcing contracts out there, so not everyone's on the same playing field when it comes to how they source their medication. Chains have one method of sourcing. We have, as independents, a different sourcing method. So NADAC can get skewed sometimes when it comes to that. If independents could, if we're going to go and look at just independents, NADAC reported as just an independent NADAC, I think would be better than factoring in the chain NADAC.
Is that something that instead of individual pharmacies reporting, that the wholesalers could report at a federal level? If they're 80% of the market.
If all wholesalers did it, there's a large market of there's a small market of primary wholesalers and a large market of secondary wholesalers. And you'd have to get all of them to report their pricing.
Okay, thank you. I appreciate your time today.
Thank you.
Next up, we have Heather Russell from Central Pharmacy in Perry and Williamston. Heather, when you're ready, please take the stand and push the red button.
Thank you for the opportunity to speak today. My name is Heather Russell. I'm a co-owner of two independent rural pharmacies, Central Pharmacy Perry and Central Pharmacy Williamston. I started working as a pharmacy technician at an independent pharmacy when I was 16 years old in Langsburg, Michigan. I quickly loved the interaction with the patients and the impact that we made in this small community. I then went on to pharmacy school at Ferris State University. I worked as a pharmacy manager at Rite Aid after graduation for 10 years. After that, I went to an independent in Okemos, Michigan. When the opportunity arose in 2015 to buy an independent pharmacy in my hometown of Perry, Michigan, I was thrilled at the opportunity and the challenge. In the last 10 years, I have seen all of my prior employers close, the independent in Langsburg, the independent in Okemos, and Rite Aid. Independent pharmacies like mine are often one of the only accessible healthcare facilities to patients. The Rite Aid in Perry closed in July of 2024, leaving my store the only pharmacy within a 10 to 12 mile radius. If my pharmacy were forced to close, the area we serve would quickly become a pharmacy desert. For many patients, especially seniors, patients with disabilities, and those with no transportation, the next closest pharmacy is towns away. This would mean missed medications, delayed treatments, fewer opportunities for patients to receive counseling, needed vaccinations, and other needed healthcare services that I provide daily. We have several patients who could not read. They rely on me to read important letters from their insurance companies explaining the details of their plans and how to use their insurance benefits. They rely on us to fill out forms for them, read them the directions, and tell them about side effects and adverse reactions. Many of our patients do not have internet access or smartphones. Ordering medications from a mail order pharmacy simply would not work for them. They do not have the technology or the foresight to order medications prior to running out. In my stores, we know our patients by name. We help them understand their medications, their over-the-counter vitamins and supplements, and check and catch dangerous drug interactions. When a pharmacy is forced to close, that layer of healthcare support disappears with it. Unfortunately, the biggest threat to the survival of independent pharmacies today is the financial pressure created by pharmacy benefit managers, PBMs. These companies control how pharmacies are reimbursed, and in many cases, the reimbursement we receive is below what it costs us to purchase the medication. Imagine running a business where you are routinely required to sell products at a loss, not to mention not being paid for the clinical services you provide. We're filling the prescriptions, checking for therapeutic duplications, drug interactions that our patients and doctors rely on. Our clinical services include spending time counseling the patients so they know how to properly take their medications and dangerous side effects and adverse reactions to look out for. We administer vaccinations, we do blood pressure checks, provide compliance packaging, and delivery for those who cannot come to us. I even provide at-home vaccinations for those who are homebound. Compounding the problem is that PBM contracts are not negotiable. Independent pharmacies must accept the terms presented or lose access to those insurance networks. Most of our contracts are ongoing, and the only way to not accept their terms is to opt out. Opting out hurts our customers and affects our script volume. We have no meaningful ability to negotiate reimbursement rates or contract terms. We're also threatened by PBMs that our contracts can be dropped by them at any point. This imbalance leaves small pharmacies with little leverage and makes it increasingly difficult to remain financially viable. I'd like to give you an example of what Express Scripts, ESI, did to us after Rite Aid closed in 2024. We were encouraged to switch to a rural contract with ESI, which promised higher reimbursement rates to the pharmacy due to no other pharmacies with a 10-mile radius. The terms sounded good, so we made the switch. Without knowing, our ESI customer copays drastically increased with a contracting change. By being a rural contract, we were no longer a preferred pharmacy. Our increased revenue came from increased copays from the customers, not the PBMs. We quickly lost customers as they could not afford their copays with us. We lost many of them to ESI's mail order pharmacy. When my patients called ESI to inquire why Central Pharmacy was charging them a higher copay, they were encouraged to switch their prescriptions to ESI's mail order. We then very quickly decided we wanted to opt out of this rural contract. The contract change back was anything but quick. When we agreed to switch to the rural contract, the change was made within days of us signing that contract. When we decided we wanted to switch back to our original contract, it took over 4 months to get out of that rural contract. As any pharmacy owner can tell you, you do not get the opportunity to speak to anyone at ESI. It's just constant emails to people who push you to the next person, all while we lose customers and they gain them. This is an example how PBMs have all the power with our contracts. There was no negotiations with them. While current laws have added some audit protection from extrapolation audits and recouping on basic clerical errors, the PBMs find new ways to recoup. Just yesterday, I received a claim review from CVS Caremark and a prescription validation request from Optum. These requests are weekly attempts to recoup money on high-dollar claims. Optum sends me a prescription validation request at least several times per week on high-dollar claims. This is yet another way they get around current audit laws. They're not looking at safety. They're looking to see if I have made a clerical error so they can recoup these high-dollar claims on medications that I have already bought and dispensed to the patient. If they were worried about safety, they could stop the claim at the point of service for an additional check with our staff. These are daily attempts to force independent pharmacies out of business. Over the last 10 years, I have had countless audits and investigations. Well, PBMs don't call them audits any longer. They now call them investigations, and many times indicate we are committing fraud. They claim they do not need to follow audit rules if it is an investigation. Prior audits and now investigations take anywhere from 40 to 80 hours of labor from myself to prepare for. The PBMs only look at high-dollar claims in attempt to recoup high dollars from us. While we have never had to repay anything substantial, it is frustrating because they claim these audits and investigations are for the safety of the patients. If it were a safety measure, they would investigate a range of medications, not just the highest priced medications. I once asked an auditor at the conclusion of a CVS Caremark audit why they didn't audit inexpensive medications like amoxicillin and lisinopril, and she point blank told me she would never meet her quota if she audited those claims. Current investigations work the same way. The result of decreased reimbursement, loss of prescription volume caused by PBMs designating independent pharmacies as non-preferred and forcing clients into PBM-owned mail-order pharmacies has significantly reduced our revenue and forced difficult decisions in our pharmacy. At this time, reimbursement rates continue to decline while the cost of operating the pharmacy, rent, utilities, wages, insurance, computer software, and maintaining our facilities continues to rise. Because these costs are out of our control, the only place for us to make cuts is staffing. We have been forced to reduce staff hours, which places additional strain on the pharmacists and technicians who remain. This increased workload can ultimately impact patient safety. This is why a growing number of independent pharmacies are forced to close around the state and the country. Each time a pharmacy closes, patients lose access to a trusted healthcare provider, and communities lose critical access to medications and care. If my pharmacies close, it won't just be a business shutting its doors. It will mean elderly patients, disabled patients, and patients without reliable transportation struggling to get life-saving medications. It will mean longer travel times, longer wait times, and fewer healthcare professionals available to help manage chronic conditions. While we have some basic regulatory functions here in Michigan, that hasn't changed the fact that we are slowly being strangled by these PBMs. I urge you to consider policies that bring transparency and fairness to PBM practices to ensure pharmacies are reimbursed at sustainable levels and protect patient access to community pharmacies. Thank you for your time and your consideration.
Thank you, Heather. So I just want to go back to the 2022 changes. What did we miss?
So the 2022 changes, they went into effect January of 2024. So what that eliminated for me, a lot of times we saw that DIR fee. Is everyone familiar with DIR fee? Direct and indirect recoupment fees. They used to do that right, like at the transmission or when we were processing that claim. So we knew at the point of sale, okay, they're gonna pull back, $3 on this claim. The PBM wants $3 to themselves. They're gonna pull that back. So it eliminated them being able to do that. So we would know what we were getting paid at the point of sale. However, like I said, these PBMs, I feel like are always 2 steps ahead of everyone in this room. They've got more people working for them. I mean, they're always ahead of us, so they're just finding ways to still under reimburse us. So now we're not seeing that DIR fee at the point of sale. We're being either under reimbursed for the medication and then not being paid for our clinical services of dispensing.
Okay. We're actually at time. We can't go on any longer. We're going to continue this conversation next week. I believe we have diffs coming in next week as well. Thank you, everyone, for your time today. There being no further business before the committee will stand adjourned.